Hello, everyone. Thanks for joining us today. Welcome. My name is Gloria Jang, and I am a third-year medical student at Lincoln Memorial, DeBus College of Medicine. And together with Maria Kristeva, she's at R3 at Mallinckrodt Institute of Radiology, we will be moderating today's session. So today's session is on physics cases, and I have the great pleasure of introducing Dr. Rassner as our faculty for this case-based review. So Dr. Rassner is a professor of neuroradiology and medical director of MRI and CT at the University of Utah. He chose radiology after learning MRI physics. He was 2022 Brad Disford Distinguished Educator Award recipient. So fun facts about him are that he commutes to work on an electric scooter and loves astronomy. We are thankful for Dr. Rassner, and he has volunteered his time today to share his knowledge and expertise with us by bringing some awesome cases for us to learn from. So now to you, Maria.
Thank you, Gloria. My name is Maria, and I'm in R3 at Mallinckrodt Institute of Radiology. I will go over the logistics now. This session is going to be a traditional hot seat style review-based lecture. Dr. Rassner will be showing cases, and we will be calling upon the residents who volunteer to take cases, but we only have one. So if you would like to volunteer, please let us know. Alternatively, we can try to do maybe chat for answers. So please also chat your questions, and then we'll answer them at the end of the session. So we'll be monitoring the chat and trying to minimize the interruptions, and so we'll review them at the end. Right.
All right, I will turn it over to Dr. Rassner.
Yeah, thank you.
Okay.
So whoever wants to take the first.
I can go first, and then maybe we'll go in the order of the chat.
Okay. And some of it is questions with images, some are just questions. So.
What is the difference between and units of absorbed dose, equivalent dose, and effective dose? So absorbed dose is a dose of just like per mass, a dose like energy per mass.
Correct.
Equivalent dose takes into consideration I think the type of energy. And then effective also takes tissue sensitivity into effect.
Excellent. And do you remember the dose units that we're using?
Well, first, probably maybe watts per kilogram. I don't know.
So watts per kilogram, that's from MR. What is power? You said energy. Do you remember the unit for energy?
Joule.
Joules, yeah. Joules per kilogram. And there's a unit that, so the breakdown of that unit is joules per kilogram.
Mm-hmm.
It's actually for all three of them, which makes it a little confusing. So good. So I have a couple more questions before we go over kind of the different units.
Mm-hmm. What is the difference between in units of Kerma and exposure, and how are they measured?
And I'm not sure if you want to take several or if you guys want to take turns.
Yeah, we can take two at a time, I guess.
Okay.
Kerma is measurement, I guess, in CT, right, and fluoroscopy. Yeah, I didn't know how to articulate the difference.
Yeah, that's fine. And we don't use them as much, so that's why I'm bringing it up. And then there's a companion to that. Would air Kerma be a good measure of total effective dose in fluoroscopy?
No, I guess it wouldn't take into account like backscatter.
True, yeah. Actually, the measurements that we do in fluoro never take that into account, which is a problem. so we sometimes use air kerma, and we also use the they're different Röntgen area products or dose area product. And so they tell us a little bit different things. And do you know what air kerma is a reasonable measure for?
Like I guess radiation in CT, like dose in CT,
Yeah, in fluoro. I'm
in
sorry.
fluoro. No.
Yeah. Okay. So peak skin dose is a measure for that. So when I think of the different radiation units, I kind of think of them a little bit in succession. Exposure is ionization of air from Röntgen rays and so X-rays. And it's really only defined for that and air. And so we still use that, for example, to define an output from an X-ray tube. So that is often still measured in that with a certain setting, how much radiation is it putting out. And it's named after Röntgen, of course, so for X-rays and gamma rays, that's the only ones that it's defined for. And it really measures the ability to ionize air. And so it's charge per mass. And it's measured with an ionization chamber. Kerma is the kinetic energy transfer to charged particles, and it's for indirectly ionizing radiation, X-ray, gamma rays, neutrons as well, which we don't have in regular radiography and CT. And it's the kinetic energy of charged particle initially created. And that's what the acronym stands for, kinetic energy released in matter. And it can be air, but it can be other as well, while exposure is always in air. But we also measure it with an ionization chamber. So the way we measure it is the same. And so you basically can convert them and can also tell it to report one or the other. And it is a reasonable estimate of the absorbed tissue dose because it does it doesn't change very much over the energy range that we use relative to dose to tissue. But it does not take into account the exposed area. And so that's why we can use it for peak skin dose, ignoring though which skin is exposed. So it's always assuming it's always the same area of the skin. So it doesn't account for dose spreading, but it doesn't take collimation into account. And the dose area product does. And so the dose area product is a better measure of total radiation to the patient. Absorbed dose, and the unit for kerma is gray, and that's joules per kilogram. Absorbed dose is what we use in CT, for example, for our CT dose index, and it's just energy per mass. And it's for any type of ionizing radiation. And the old unit for that was rad, with 1 rad being 10 milligray. The equivalent dose, as you said, takes into account the type of radiation, and so it adjusts for how much damage essentially the different types of radiation can do with the same energy. And so we have this additional radiation weighting factor. What makes it easy for us for X-ray, gamma rays, and also beta rays, it's 1. So the number in absorbed dose is the same number in equivalent dose. And it's still defined as joules per kilogram, but we use the unit sievert. And the old unit for that is rem, Röntgen equivalent man. And then the effective dose takes into account the sensitivity of the tissue that's exposed. And there have been different ICRP reports. The latest one is 103. So it assigns a proportion of harm and detriment from radiation of that tissue. And we compare it to uniform whole body radiation. And so if we look at the table, all those individual weighting factors add up to 1, basically saying when we expose the entire body, then whatever effective dose is the same as our equivalent dose to that tissue. And so this is more akin to the risk of harm to the patient. And so there were different iterations of those weighting factors, and some regulatory agencies still use older ones. Okay, which takes us to the next case.
Awesome. I think it's Hawaida is next.
Yes. Okay, so case 4. What is the CTDI? So I guess the CTDI, we can extrapolate that from the chart. So
what does it tell us in essence?
So I'm not sure.
Okay. Do you remember what it stands for, CTDI?
Yes, so it is computed tomography dose index.
Exactly right. And MSAD is not one we usually encounter. Do you remember what that stands for?
No, I don't know what MSAD stands for. What does MSAD stand for?
And so that's, if we're doing the questions pair, so how did the scanner, or how does it arrive at these CTDI numbers?
So basically it's calculated from like single slice measurement. So basically we will do I know that like we will do the area divided by the time, but I'm not sure.
Okay.
But I know that it's based on a single slice.
Yes, so the CTDI we can think of as the dose to a slice. And does it represent the dose to a slice in the patient?
No, it's related, it does not reflect, and it's related to the phantom.
Exactly right, very good. And that's a really important part. And I don't know if the next person wants to take this, or if
yeah, I think we're taking 2 at a time.
Okay.
So what is the difference between CTDI volume and CTDI-W? So I know that we calculate the CTDI weighted from, we calculate the CTDI volume from the CTDI weighted.
Correct.
So it's basically CTDI volume, it's 2/3 the peripheral CTDI weighted plus 1/3 the CTDI central CTDI.
Yeah, that's the CTDI weighted. So 1/3 central, 2/3 peripheral.
Yeah.
And do you know then how we get to CTDI volume from CTDI weighted?
So it's adjusted by the pitch.
Exactly right. Very good. So we divide it by pitch, and that gives us CTDI vol. And DLP?
So it is the dose length product. So I know that we multiply the CTDI volume by a weighting factor, which is different for each CT. Let's say like CT of the head is going to have different factor than CT of the head and neck, different than CT of the abdomen. So each one has its own factor. So we multiply the factor by the CTDI volume to obtain the DLP.
Yeah, and the factor is actually the area that we're covering. So what area we're covering, and that's why it's in centimeter. So you can think of it as the CTDI times the scan length.
Okay.
Very good. So MSAD is something we don't use a whole lot, but that's sort of thought of as the gold standard, even though we never see it. But the important part here is that when we scan in CT, the dose to our slice is always the dose from actually scanning that slice, but also the dose from scatter from scanning adjacent slices. And so the MSAD basically measures our slice and when we scan it, but then also measures the dose to the slice when we scan adjacent slices. And so it's a more labor-intensive process. What the CTDI does is kind of tell us the same thing, but in a more simplified way. So the idea is if we have our slice, and let's say we just look at 5 slices here, the dose to our slice is the slice from scanning it, plus the scattered dose when we scan slice 4, for example. But then you can argue that whatever slice 4 scatters into slice 3 is actually the same amount that slice 3 would scatter into slice 2. And that's true for any slice. So whatever slice 2 scatters into our slice 3, 3 would scatter into 4. And that's also true for slice 1. Whatever slice 1 scatters into 3, 3 scatters into 5. And so the idea is then, rather measuring the slice over and over when we scan adjacent slices, we can just scan this one slice and measure the radiation across the phantom and all the amount that's scattered into adjacent slices, arguing that whatever our slice scatters into the other slices is the same as the other slices scatter into our slice. And so it's done with just one measurement. And as you had said, we always use a phantom. We only have 2 phantoms, a 16 and 32 centimeter phantom. The 16 is used for heads and kids, and the 32 for the other scans. There are dosimeters that we can put in there at the 12 o'clock, 3, 6, and 9 o'clock and center position. And so the CTDI weighted, also as you mentioned, takes into account the dose change in the center versus periphery, and takes 1/3 of the center plus 2/3 of the peripheral dose. And the CTDI volume then adjusts that for helical scanning. And so it's CTDI weighted divided by pitch. The DLP is the dose length product, and it's the CTDI value times scan length. And so the unit we use is milligray, so absorbed dose times centimeter. Okay, that takes us to the next case here.
Yeah, I think it's Mr. Anurag.
Yeah, I'm here.
Okay.
Okay, so what is the estimated effective dose for the patient? Here looks like the DLP is 2080, and we're scanning the abdomen. So the effective dose is 2080 into the tissue weighting factor.
Correct. And do you know what factor we can use ballpark?
0.15.
Okay.
So it would be like 2000 into 0.15, closer to 300.
Yeah. So yeah, I know the RSNA modules in APM, they do this 0.0 something. I always do 15 and then divide it by 1,000. But it gets you there. So 30 divided by 1,000, and then so you would get that factor. Very good. So it's a very crude estimate, and they have more precise numbers, but since it's not a very precise estimate anyway, I think it's just easier to use 2 for the head, 5 for the neck, and 15 for torso, and then divided by 1,000, and that gives you millisieverts. So here it takes us to about 30 millisieverts.
Okay.
Very good. And so, yeah, in the RSNA modules, they have, for example, for the head 0.022, but it's, I don't know, I find that harder, even though it's essentially the same thing. So here's a companion part. Did we underestimate or overestimate the effective dose, and why, if we use this estimation?
Okay, so the person is pretty big.
Correct.
So weighting factor should have been, I guess the peripheral radiation all went to fat, the central radiation went to the body. I guess we overestimated, but I can't really articulate why.
Yeah, no, that's good. And it's a little counterintuitive, and that's why I want to bring it up. And so the idea basically is we always have some internal shielding. So the radiation will go through other tissue before it reaches a certain point. And so, for example, if we think about a 16 centimeter phantom, and sorry, I'm not sure that overlaps a little here. But if we think about a 16 centimeter phantom, the radiation to the center has to go through 8 centimeters of material before it gets there. So it will be somewhat attenuated. But in the larger phantom, it has to go through 16 centimeter of material before it gets there. So it will be more attenuated, and therefore the dose will be lower given the same technique. And that's true for any point. If we look at the surface on one side, if we just look at 2 directions, so if the beam comes from the left, and it would hit it full strength. If it comes from the right, it has to go through the entire phantom. And again, with the large phantom, it has to go through more material. So if we use a certain technique, the smaller the patient, the higher the dose to the patient. And that's important for pediatric scanning. So if we use an adult protocol for a pediatric patient, they will get a higher dose than the adult. And so we always need to adjust the protocols. In the adult world, if the patient is larger than your phantom, then we would overestimate the dose. And if they're smaller, then we underestimate. And there's a correction factor we can use. So we use an effective diameter by looking it up, adding together the lateral and AP diameter. And then we can get this conversion factor, which adjusts the dose. And just a ballpark, if you use the same technique on a large phantom, you will get half the dose of the same technique on the small phantom. And so that's also referred to as the size-specific dose estimate. All right. Next question, and that's a little bit more open one.
I think it's Kunal is next. Kunal.
Hi. Yeah, my name is Kamal. Okay, what can be done to reduce dose in patient in CT? Let's see, you can increase the pitch. I think you can decrease the field of view or increase collimation. I know that's more something you see in fluoro, but I think in CT as well. Let's see. Those are kind of a couple things I can think off the top of my head.
Yeah, or just in terms of like good technique, what would we consider good technique?
You can see. I'm not sure what other factors.
Okay.
Are you like talking about like KVP and MA and things like that?
Yeah, so that's part of it. We want to have the proper parameters set for the exam we're doing.
Okay. Yeah, so you could like do things like increase KVP, decrease MA. Yeah.
And is there something that maybe the scanner can do to help us reduce those or our reconstruction?
I'm not sure. I know typically I think we could use like iterative reconstructions and things like that.
So that's exactly right. So if you have certain reconstruction algorithms that introduce less noise or reduce noise in your image, then you can scan at a lower dose level. So those are all things we can do. So and the more basic thing is we should only scan when it's really needed. And as you guys all know, that can sometimes be a struggle, that exams might be ordered where we feel that may not be the best imaging, and we can talk to the clinicians. Appropriate coverage and technique. So we shouldn't, when we scan an abdomen, we should not see, clavicles or so. Proper technique and proper protocol. So we shouldn't use a triple phase exam if we're looking for renal stones, for example. Dose modulation is also something the scanner can do, and modulates in Z-axis and angular. direction, iterative algorithms, which you mentioned. With some scanners, particularly older scanners, if you actually collimate narrows to get high resolution, then the dose will be higher. And if we're scanning with exposing a larger part of the detector and binning, then the dose will be lower. And there was a question in the chat, I'll get to it after this round. Are you familiar with overbeaming and overranging?
Yeah, I think this is kind of applied a lot in like cardiac CT, I think, but I think it also kind of refers to the pitch. So overbeaming, you're like scanning a greater area to the point where it's almost like redundant, and like in cardiac CT that would be important if you're going to do reconstructions to evaluate function. And I think that's like totally would occur like at a lower pitch. Overranging, I'm kind of forgetting.
Okay.
This one is.
And so you're definitely correct that with cardiac in particular, where we have very low pitch values, we radiate the tissue more, and that increases those. We don't usually use the term overbeaming for it. So overbeaming basically refers to the penumbra of the beam. When we collimate the beam to hit the detector, we generate a penumbra. And with multi-row detector scanners, we cannot use that for scanning, because effectively the MA, or the photon flux in those penumbras, is lower than in the central beam. And that would mean that the first and last detector row that we're using would get effectively lower MA and noisier data. And that would create problems with the reconstruction. And so we collimate the beam that always the full beam hits the detector, and this wasted radiation will be in the patient. And it gets worse when we do cardiac scanning, for example, because with a very low pitch value, we move the patient very little through the scan. So it takes multiple revolutions to cover the area, and every revolution basically introduces two of those penumbras that are wasted radiation. Overranging we see in helical CT, because we will need typically 360 degrees of data for the first and last slice. And so we will start to scan some tissue outside that slice, and that doesn't need to be scanned because that's not what we wanted. Now with overranging, some newer scanners have special collimators that can cut off the beam, so it doesn't happen. So overranging is something that can be addressed. Overbeaming is always inherent in the beam, and we can affect how much of it we see by determining what beam collimation we have and what our pitch is, but we cannot get rid of it. And so there was a question with the table for the size-specific dose estimate. And I think part of this factor here, I think the question was with the value, why is the correction factor not 1 with the 16 or 30 centimeter phantom rather than 35.5? You know, I'm not entirely sure why they picked 35.5. I think it probably is because they went in increments of 2 centimeters here. If they went in increments of 1, we would have 36 exactly here. And so it was just in between those two. I think that's the only reason. Okay, let's see. So we had done that. Okay, so here's the next question.
Yeah, I think it's Yuhao Wu.
Yeah. What causes this artifact in a water phantom, and what can be done against it?
So this change where it looks darker in the center.
I'm not exactly sure what it is, to be honest, but
okay. All right. So this artifact is called cupping artifact.
Okay.
Do you remember what causes cupping, or have you heard the term?
I think I've heard it before. Is it that, no, that's ring. Is it some of the photons in the scanner is not hitting part of the detector?
Not hitting, no, not directly. So it's, and you know, if you haven't seen that, then that's why we're doing this, to
Okay.
learn something. It's an effect of beam hardening. And so when you take something like a water phantom, in this case, the central beam needs to go through more material than the peripheral beam. And so we will get more beam hardening effect. So with the average energy of the photons will increase more in the center. And so the scanner basically just sees, because the higher energy beam gets attenuated less, the scanner just sees, oh, there are more photons relative to the size coming out, so there must be less attenuation in the center. And it leads to this artificial drop in the center. And it's something that you can sometimes see in head CTs. When you make the window really narrow, you can see that it looks a little darker in the center. Or if you, as you progressively narrow the window, it looks like the brightness is coming in from the outside. So that's something. And we can use a bow tie filter and calibration software to correct for that. So the bow tie filter essentially just does the opposite of what the phantom and our patient do. So it hardens the beam less in the center and more in the periphery. So that's the energy distribution, and the photon flux is more similar at the detector. And we typically don't see it in body because the window is not that narrow. That's really it. Then head CTs, we use a much narrower window, and then you tend to see those artifacts more. Okay, so here's the second case.
What is the most likely cause of the streak artifact? Is it again like beam hardening from the attenuation by the attenuation of the lower energy photons from the bones?
It does look like it. Now, when you recall the head CTs you have looked at, did you see that much streak?
Usually not.
Usually not. And here it's hard to tell on this brain window, but the bones were not particularly thick either. So it was kind of an average skull. And
okay.
Maybe as a clue, if you just look at where the scatter, if you follow the direction of the scatter, where is it pointing to? So if you follow here, where do they come together, the different streaks?
Different streaks.
And this, there's somewhere, they would meet somewhere out here. Right?
Okay.
So can you think of something that could interfere with a head CT where we did something wrong?
I'm not sure.
Okay. And so this is an incomplete projection artifact, and it looks very similar to beam hardening, where we also see streaking, but it's because the patient has their arm above their heads. And it makes it problematic because the scan field of view, typically in CT at the maximum, is around 50 centimeters. And so if the patients put their arms above their head, they extend beyond our scan field of view. And that means that we don't, or the scanner doesn't see the arms in all projections. So when the tube is in AP direction, the arms are outside the beam. But when the tube is left right, the arms are in the beam. And for reconstruction, we always assume we see all the tissue all the time. And so when there's some tissue that's sometimes in the beam, sometimes not, then it causes a lot of streak artifact. And so and that's why the streak seems so particularly intense and more than what we would expect. And also, I mean, if you think about the how dense the arms are, they're really not that dense, and so it's more than what we would expect. So if you have the arms in the beam where you can see them, you might get a little streaking artifact, but not that pronounced. So once it gets outside our scan field of view and is only in some projections, then it will be just much more pronounced. So the streak will be more excessive than you would expect to see. So, okay. And there was a question, let's see, about cupping vignetting. So vignetting is more in an image chain where there is less radiation, for example, hitting a detector in the periphery because of the way the beam, it's not a beam hardening artifact. So it's a hardening effect and an attenuation effect. It's not that the beam itself is not as homogeneous. With an II, you can see some vignetting where just from the amplification process, there's less signal in the periphery. But in cupping, it's just a difference in hardening of the beam. The beam is more hardened in the center, and so will be less attenuated. And that leads to this artificial appearance of drop of attenuation in the center. And does this mean, there's a question that streak artifact during complete projection, it's a type of beam hardening artifact? Well, it's beam hardening certainly plays a role. Beam hardening is always there, but I think the main problem is it's a reconstruction problem because there's inconsistent data. Something is in the data sometimes, but not all the times. And whenever there is inconsistent data, it tends to create artifacts. And so beam hardening probably contributes a little bit, but the main thing is the data inconsistency. Okay, so we have the next case.
Yeah, we have Mitch who has volunteered.
Well, thank you for volunteering.
Hello.
Yeah.
Oh, this is mine. What's the cause of the streaking?
Yeah, this left, right.
It's left to right streaking. So is this when the patient's arms are down at their sides?
Okay.
Kind of
And
at the
here-
thoracic inlet. So, oh, it's because the shoulders.
Yeah. And so
So
what's with the shoulders?
It's attenuating the beam. So you're getting a bad signal to noise ratio, I believe.
Correct.
So you need to increase the KVP.
You could increase KVP, yes. Is there another thing the scanner can do to help us with that?
I guess you could wait. Can you obtain thicker slices, I believe?
You could do thicker slices. So that is something you can do even afterwards. If you do basically an axial MPR and just make the slice thicker, that will reduce it a little bit because it tends to average out those streaks, which are randomly bright and dark. And so that would reduce the effect, definitely. So the other thing, and it's a little bit guess what I'm thinking, it's noisy projection, and we call that photon starvation. When there's a lot of soft tissue, then so few photons make it through. And it's really quite staggering how few. So we're for 50 centimeters soft tissue, and the typical energies that we do, 0.0004% make it through. So a really small amount. And so thicker slices reduce the artifacts, so we can trade basically spatial resolution for signal to noise. The scanner can also do what's called an angular dose modulation, where it increases the MA when the tube is left right and decreases the MA when the tube is front back. And then a suggestion you made, increasing KV increases dose, but that will increase dose in all projections, even the ones where we may not necessarily need it.
Okay.
So here we have two slices from the same acquisition, one reconstructed in 1 millimeter, one reconstructed in 4 millimeters. And so what's the difference in signal to noise?
Is this mine as well?
Yeah, I think we're doing pairs.
Oh, on the thin 1 millimeter slices, your signal to noise ratio is lower.
Oh, do you know how much lower?
Oh, by is it a factor of, well, it's a difference in from 1 to 4 millimeters. I can't remember the conversion. I'm gonna just guess factor of 4.
Okay, so it's actually a factor of 2.
Okay.
And so that's something, the reason why I was showing that is it's different in MR. In MR, it actually is a factor of 4, but in CT, it's different. And so there's a companion case, I'll go over that afterwards. So I don't know who is up or who wants to take
Yeah, I
that.
think it's back to Maria. She volunteered again.
All right, so on the one with MAs of 166, the signal to noise will be lower.
Uh-huh.
And I think in this case, it's directly proportional. So maybe like 6 times lower.
So I tried to get it about 4 times. It was hard to find 2 images.
Okay,
but
4.
it happened. But,
My math, yeah.
so a signal to noise in CT, and so the reason why I want to talk about it is that it behaves differently than MR. And so the way I think about it is how many photons go through the voxel and can arrive at the detector. And the signal to noise is a square root relationship. So if we double the voxel size, for example, so we get twice the photons going through, then it goes up 1.4-fold. If we quadruple the voxel size, so for example, slice thickness going from 1 to 4 millimeter, then our signal will increase 4-fold, but our noise will increase 2-fold. So when we just think about the statistical noise, the signal is the number of photons, and the noise is the square root of the number of photons. And so 4 times the number of photons means 4 times the signal, twice the noise. So the improvement is 2-fold. And that is also true if you do it with MA. So in both cases, the one case had a quarter the MA, the other case had a quarter of the slice thickness. The effect on signal to noise is the same. So 4 times the slice thickness or 4 times the MA means double the signal to noise. But it means 4 times the dose when you do it with MA. So it's a pretty expensive way of doing that.
Which image looks noisier and which image likely is noisier? So noisier looks the soft tissue one.
Yes, correct. And which one likely, if we quantify noise, measures noisier?
Probably bone.
Bone, correct. And so what's the difference here? Just the window is different, but what do we usually do in addition to the window when we look at the bones?
I think the kernel was like how I would do the smooth or sharp reconstruction.
Exactly right. So the bone is usually a bone kernel, a sharp kernel, and those tend to be quite a bit noisier than the soft tissue kernels. Very good. And I have a couple companion cases, so we'll discuss them all together.
Okay, I think now everyone can just kind of chat, place their answers inside the chat.
Or should we go with the same people like round then?
Yeah, we can just take turns. I have a total of about, I think, 50 cases. So
Okay, yeah, if Hawaida, if he's still here, or she's still here.
Yes, I'm still here.
So do you know how we can quantify noise? in
NCT. Okay, I don't know if we use a noise matrix, but can be just measured by the standard deviation of the noise.
Very good. Yeah, so the standard deviation. And so do you know what we use when we do our quality control on the scanner? Where do we measure standard deviation?
No, I'm not sure.
So we usually use a water phantom. And so the reason I mentioned that is that the water is just very homogeneous. And so we want to measure in something that's homogeneous, because if we measure in tissue, the standard deviation will in part represent just heterogeneity of the tissue rather than noise in from how we acquire things. And so we would want to measure in the ventricle, for example, or in the aorta, just in something that's homogeneous. And
Okay.
so, yeah, and so signal to noise is affected by the MA and KV, but also the reconstruction algorithm. Sharper always means more noise. And but the window makes a huge difference in what we perceive. So here I've taken a bone algorithm and windowed it the same as our brain algorithm. And now it's obvious that this is far, far noisier than this. But if our window is wide, then we will not perceive noise very much. And so if we think of noise as this random fluctuation of CT numbers, and so here plotted in red, if we have a narrow window, this noise level means because of noise, some pixels will go white and some will go black. While if we have a really wide window, even though it's the same amount of noise, it just changes the gray, shade of gray a little bit, but it will not be very apparent to us. So narrow window always means noisier appearance. And you may have noticed that in stroke patients, when we make the window really narrow so we can see those subtle changes in the loss of gray white or so, the images look very noisy because we just see the noise better. The wider the window is, the less we see noise. And so even though bone algorithm is noisier, because of the wide window we use for the bone window, it usually looks less noisy. And so here in this example, I drew the region of interest in the CSF, in the ventricle, and the standard deviation, as I said, is a good measure of noise. And so in our brain algorithm, standard deviation is 3.3, while in the bone algorithm, it's 67. And you can see it doesn't matter how it's windowed, it's the same data. So the measurement doesn't change no matter what your window level is. The window just is how we portray the data, but it's the same data. But it certainly looks noisier when it's a narrow window. Okay, here's the second case.
So what is the most likely explanation for the changing hypoattenuation? So we see initial 5 hours later and then 2 weeks later. I believe like initial we have like a stroke, acute stroke. So we lose the gray-white matter differentiation. And then we start regaining the gray-white matter differentiation over time. Maybe that's like fogging effect of the infarct.
Okay. So, and fogging can certainly do that. It would be a little unusual to do that in such a short time frame. It tends to be more on the order of days. So here it's more technical reason, because 5 hours later, it looks like the other side is abnormal. And then 2 weeks later, everything looks fine. Can you think of a technical reason why, what could cause that it looks darker on one side than the other?
So what I know that like the stroke window is the best window to see this. So maybe we have a larger window on the other acquisitions. I'm not sure.
Yeah, so window was the same. So
The window
what this is, where do you recall what we can do to correct for beam hardening, the cupping artifact?
Yes, we can increase the dose like that to correct for beam hardening, right? The like through the KVP. So
Through
we have
KVP?
more penetrating photons.
Yes, and we use this bow tie filter, right?
Oh yeah, okay.
And so the thing, and that's something we don't see it as often, but I wanted to show it because it happens in real life, and sometimes things that happen in real life also show up in exams. It's the bow tie filter doesn't know where the patient is. And so it's not individually adjusted for the patient. The bow tie filter assumes the patient is centered. And so when a patient is not centered, then it basically, the correction doesn't fit the patient. And it can harden the beam more here on the periphery and then make it look darker. And then it's on the other side. And at least in our institution, we tend to see that more with trauma patients because they often don't use the head holder for trauma patients because they're in a C collar and, you know, they need to be quick. And so when they're just on a plain table, it's easier for them to be off to one side or the other. Well, if they're in a head holder, their head position is fairly fixed. And so here it's just off-center positioning. And then on the 2 weeks later scan, you can see that they use the head holder. So you can see a little piece of it here. And so it's something you can sometimes see when you look at the localizer or the scout image or topogram, whatever you call it. You can often see if they use the head holder or not. And so that can raise your suspicion if they didn't. Sometimes if you make the window wider, you may see part of the table, which is often curved, and that may give you a clue if the patient is off center or not.
Okay, thank you.
Yeah. So this is our bow tie filter. When the head is centered properly, then the correction fits. But if the head is off center, then it will not fit. And so it can make it look like one side is darker. Okay.
All right, we have Elizabeth coming up next.
All right, this is a question about why this coronal NPR looks strange. My first guess was going towards patient motion, but that's probably not the answer. How about changing the pitch? And then you might get better Z-axis like spatial resolution.
Yeah, so you're on the right track. So let's say we did that ourselves on PACS. And so I'm referring specifically here to this, what looks like stair stepping. And do you know what can cause that when we do our NPRs?
Too large of a slice thickness?
Exactly right. Yes. So the slices are too thick. And so we get the stair stepping. And so what could we do to improve it? We have scanned the patient. What could we ask the tech to do to get us better quality NPRs?
They can send us thinner slices usually.
thinner slices. And there's actually another thing they can do in addition to thinner slices.
Maybe like an iterative reconstruction that might do some smoothing.
Iterative would reduce noise a little bit. I don't think it would reduce stair stepping per se. What about slice positioning?
Oh, I'm not sure.
So overlapping slices. So whenever you want to do your own NPRs, we sometimes do it with CTAs if there is something that looks odd and I can't see for sure. Might there be an aneurysm or maybe a fenestration or something? I often ask the text to send me thin slices so I can do my own NPRs and move them around. And I always ask them for 50% overlap. And that will, in addition to the thin slices, increase the quality of your multiplanar formats. Okay, what's the difference between volume rendering and maximum intensity projection?
I think volume rendering is like an MPR. It's like a mean projection versus a minimum projection.
So on the MIP, what does the scanner look at? Or what is it showing you?
On a MIP, sorry, that's a maximum projection, and it's looking at everything that is the brightest, like lung nodules in the background of black lung. It's looking at those nodules.
Correct. So it shows you whatever is the brightest. And so what's a drawback of doing that?
Then you're going to like smooth, if you are looking at something that's like in the mid-range or has like low contrast, it's gonna like kind of filter it out of the image.
Correct. Yeah, it can make stuff disappear for sure. Also, yeah, if they're just other things that we're not interested in that are brighter, then they will be shown, not whatever we're interested in. Correct. And with volume rendering, do you remember what exactly we do for volume rendering?
I thought you took the mean value of the pixel and showed that.
Well, yeah, we do something in addition. So let's just look at that. So MIP, as you said, we only look at the brightest voxel along our path. It's pretty fast because we only look at the brightest thing. It tends to include the noisiest data because that can be artificially the brightest, and the background gets brighter. So those are all effects of it. One important thing also is there's no depth information, but your eye tries to tell you, or your brain, that there is depth information, because just from the real world, if something is contiguous and interrupts something else, then the contiguous structure is closer to us, and what's interrupted is farther away. But in MIP, it just means whatever is contiguous is brighter. It doesn't mean it's in front or more superficial, but your brain tries to tell you that, and so you just can't rely on that, and you need to ignore that. For volume rendering, we actually go through voxel by voxel, and depending on thresholding, for example, we will assign a certain color often, but also a certain opacity. And so we can make tissues partially transparent. So here, for example, I've reduced where skin lives and made it more and more transparent. So you still see this ghost of the skin, but you can see the structures underneath. And so this change in opacity is something that's unique to this volume rendering, and it can give us a more 3D appearance and allow us to put things a little bit more into perspective. Okay.
All
Next.
right, and yeah, an anurag or onurag is next.
Yeah, what is this artifact and what can cause it? So, I think it's, I want to say it's like a ring artifact, but not just one ring is defective. It's like more than.
Good. Yeah. So lots of them.
Yeah.
And one thing that can cause it, you already mentioned, so a detector defect could certainly cause it. Would be a little unusual to have that many detectors defective.
Yeah.
What else could do that?
So it's just, I guess, a calibration error.
Very good. Yeah, a calibration problem. And so, and that's why I want to show you this. So there can be two ways you can get to this calibration problem. One is that just the calibration is off and the scanner needs to be recalibrated. And that can be because over time, the calibration just things change and then it needs to be recalibrated. It can also be that it could be incorrectly calibrated. Maybe when the service was there, something went wrong and the calibration was off. We had that happen once on one of our scanners where the phantom that was used had a little air bubble in it and it messed up the calibration. And so we got ring artifacts as a result of that. The other circumstance where you can see that is when we scan at a very low dose level, and then the calibration is often not accurate for very low dose levels. So in this case, there was from scanning a femur, and when we got into the pelvis, the dose level was just way too low in this bigger patient to be adequate for the pelvis. But then once we did a dedicated scan of the pelvis with the appropriate dose level, all the rings were gone. So if you're at too low a dose level, you can also start seeing rings. Very good. And so the reason that we see rings is when a detector is defective or out of calibration is that for a particular detector, for all the projections, it will contribute the most to this ring where it's basically tangential to. And so this detector element will contribute the most to this ring. And so the larger the ring, the more peripheral the detector that is affected. And we only see it in third generation scanners. How many of your scanners are third generations typically?
How many?
Yeah, pretty much all of them.
Yeah.
I've been in radiology for over 20 years. I've never seen anything but a third generation. So it's not a very distinguishing feature anymore, but it's something easy to ask. So third generation. So it may need to be calibrated or serviced if there's a defective detector. Okay, so here, next question.
Yeah, it would be Kunal.
Oh, aren't we taking pairs? Sorry.
Oh, sure.
Yeah. Oh, sorry. Go
Yeah.
ahead.
Sorry. Let me play it. So I hope the video shows. Is the video showing up okay?
It is.
Okay.
So I'll go with photon starvation or beam hardening artifact.
Okay. There's something unique about it. So let me play through it again. So the beam is kind of rotating, right? Is that something that rings a bell for you?
This is a helical scan.
Yes, it is a helical scan.
Yeah. I don't know. A friend of mine just texted me, is it a zebra artifact? I don't know what that is.
So zebra stripes is usually a term we use in MR.
Okay.
Or a case-based signal error. Or
I don't.
zebra is, sorry, no, that's a type of wrap in MR, but it's an MR artifact. Herringbone is the case-based.
Got it. People are talking about windmill, but I don't know what that is.
Yes, so windmill, that's, and so the unique thing about it is this rotation. So, and one of the options is to use thicker slices. So basically what it is an interpolation problem when we use really thin slices in a helical scan on multi-rode detector. So when we look at, sometimes the slice lines up with the detector and then it'll be in between two detectors. And so we will interpolate from both detectors to guess what it would be for the slice if there was a detector there. And then it lines up again with the detector, and then we interpolate. So we basically alternate between measuring and interpolating. And that works pretty well, except when there are very great differences in density. And so metal or bone can be enough to do that. And then the interpolation is often, so we get this alternating a little bit brighter and darker streaks, and they spin around as you scroll through the images. And so thicker slices is something that you can always do, even if the scan has been done. If you decrease pitch, that can help a little as well. And so here's an example where the first image is what I had shown you with 0.6 millimeter slice thickness, and then with 1 millimeter, and you can see that it's already quite a bit reduced. There's still some streaking and some other artifacts, but this rotating streak is much improved. Okay, next case.
Yeah, now I think we're back at, so now.
Hey, all right. Which two scan parameters were likely changed between these two acquisitions with same signal to noise ratio, and explain the reason for the different appearance? Okay. So let's see.
And maybe one thing I didn't mention, the window setting is the same.
Okay. Okay, so let's see. Well, both look like contrast enhanced CTs to start off with. The top image in general just looks darker than the bottom image. And I guess there's potentially, I mean, it looks like there's better, maybe like just contrast in the second image, like soft tissue contrast. So maybe this indicates that the KVP was modified.
Very good.
It's typically like lower KVPs would improve the soft tissue contrast. That's probably what was performed here.
Okay. And so the signal to noise is the same. So what other parameter would we have to modify to keep the signal to noise the same?
So the MAS is probably increased. So if you decreased the KVP by around like 15% or so, then you'd have to double the MAS.
Very good. Excellent. And so in this case, there was 2 images from a dual energy scan. And so on the lower KV setting that was performed with a higher MA, we see this increased conspicuity of iodine because there are more photons around the K edge of iodine. And so we get more attenuation. And if we go from, in this case, it was 140 and 80 for those 2 images, the MAS has to be 4 to 5 times for the 80 what it is for the 140. Okay, so what is dose modulation? And why do we do it?
We're at UHAL.
I think we're doing 2 at a time, right?
Oh yeah, sorry about that.
Yeah, no worries. What is dose modulation? To be honest, I'm not sure. You're obviously changing the dose, and it's probably done to lower the dose or limit the dose so it doesn't get too high.
Okay. And do you know what we modulate in CT?
I mean, is it those same factors that we just talked about, KVP and MAS?
It's actually only MA.
Okay.
So, yeah, and so that KV we changed before the scan, and we may set it differently. For example, if you do a CTA, you can go a little bit to a lower KV level because you get better conspicuity of contrast. But then during the exam in CT, we do not change the KV. We keep that the same, but we can modulate the MA. And so we do it to reduce dose, but it's basically reduce dose and maintain consistent image quality. So where the tissue is thicker or more tissue, or denser tissue, we can increase DMA. And then where there's less or less dense tissue, we can decrease DMA. And so we can try to maintain kind of the same level of signal to noise throughout the scan. And so that's referred to as the Z-axis modulation. And then in addition to that, we can do the angular modulation, where the scanner tries to partially compensate for the patient usually being wider left-right than their front-back. And so it can drop DMA when the tube is in front-back position and increase DMA when it's left-right. And the Z-axis modulation is based on the localizer. And that's why it's important to have a proper localizer. So your patient shouldn't move after you've done the localizer or topogram, because then it would assume the wrong tissue in a certain position. Okay, I think that's maybe one of the very few MR questions. We'll do the MR mostly in another session.
All right, now I think we're at you, Hal.
Okay, so patient moves a lot during thoracic spine seizure T2. Text suggests using a single shot fast spin echo rather than regular fast spin echo. What are the advantages and drawbacks? I think SSFP is where you get like just multiple echo trains. So I think like you would get faster images. What are the drawbacks? Would you be like, would it be more susceptible to susceptibility artifact? Because you're not getting the 180 refocusing pulse.
So actually it's it would be a little less because as you said, so we're reading, having those echo trains, each echo is generated by a 180. So we actually have a lot of 180 refocusing pulses.
Okay. I think you would get, if I remember correctly, you would progressively lose your signal because you're not allowing your photons to go back to their relaxed state. I think that would be a drawback.
Yeah, so, and the way it shows up in the image, because so we have this T2 decay taking place while we are reading out, and much more extreme than what we would see in a regular fast spin echo. And so the way it translates is that our contrast is not as good, and the image also is a little blurrier, so the sharpness is not as good. So that's essentially what we're trading for, having this very fast sequence. But it may very well be a worthwhile trade-off if the patient can't hold still. And if you're only looking for cauda equina or so, then that's totally acceptable, because we're looking for something big and not some small little disc protrusion or so. So single shot fast spin echo is faster, less contrast, less sharp, slightly less susceptibility artifact because we have so many 180s in there. Okay, that's a little long, my apologies. So routine non-con abdomen, 5mm slices, and there's a bigger lesion in the liver that's barely seen. What can we do to maybe see it a little bit better? And the patient
so you
is gone.
Yeah. So I'm wondering if it was scanned on a dual energy, you can, I guess, adjust the KV to increase contrast. Window
Do you have
level.
Philips scanners at your shop?
We have GE scanners, but
Okay. Yes. I'm just asking because Philips uses sandwich detectors, so they always have the dual energy information if you have those available.
okay.
With all the others, you need to plan for it and prospectively acquire it as a dual energy.
Yeah, I think ours we have to prospectively plan for it. So
Okay.
I'm wondering if there's any you probably could use some sort of iterative reconstruction to improve your signal to noise ratio, but I don't know the specifics.
No, but the very good answer. So if we can change the reconstruction algorithm, and you're going to an important point, we want to improve our signal to noise to see this low contrast lesion better. Let's say you've maxed out your reconstruction. Is there something else you could do? We have the best algorithm that we have, but is there something else we can do with the reconstruction to improve our signal to noise?
Can you do like a MIP of some sort? I'm not sure if that would be helpful.
Depends what else is in there. It could maybe work, maybe not. But what parameter in our reconstruction, in addition to the algorithm, affects our signal to noise?
So like you can, I guess we adjusted the window. We can't really adjust MA and KV, unfortunately.
Yeah.
You can, I guess, sorry, you can increase the slice thickness.
Very good. Yeah. And so, and the point here is it's a really big lesion. So even if you have a 1 centimeter slice, you're still going to see that. And so, and it'll improve your signal to noise. Excellent. So you could make your field of view larger. That would be another way to get bigger voxels, better signal to noise, thicker slices. So we're trading essentially spatial resolution for signal to noise and therefore for low contrast resolution. Very good. All right, next case.
Yeah, and we have Mitch.
What kind of study is this and how does it work? This has color on it, so I'm going to guess it's a dual energy.
Very good.
So dual energy uses two different tube voltages and calculates, I guess, the attenuation difference. That's my understanding of it.
Yep. That's exactly right.
It's
so
like
here,
140. Are they all the same voltages? It's like 140 and 80 or something like that?
It varies a little bit. 140 and 80 is pretty common. Some scanners also use 150. Sometimes they use, instead of 80, they use 100. So there are a few different, and that's for scanners where we actually acquire it basically separately, with voltage switching on a GE or with dual source scanner where we run the tubes at different ones. There are also other approaches like the sandwich detector where we cannot control those. It's basically due to filtering, or a twin beam where it's two different filter materials in it. So there we can affect it, but when we control the KV, then we can. And so there are different approaches how to do it. And so, yeah, we can then, from the change in the CT number between the different acquisitions, distinguish different materials, for example, iodine, calcium, soft tissue, and so forth. Very good. So we'll have a few ultrasound cases.
What is the assumed speed of sound in tissues for ultrasound? I believe it's 1540 centimeters per second. Something like
Exactly. Meters though.
that. Meters per second. Okay.
So very good.
All right, and now we're back to Maria.
Okay, so I think this is reverberation. What causes it? It's I think it's a pocket of air reverberating back and forth between like water molecules.
Yeah. So, and
ring down. This is ring down.
ring down. Very good. Yeah. And there can be maybe probably a little reflection, but it's also the induced vibration just in the little pocket of air. And so ring down. Very good. And so fluid, little air bubbles, and so there's vibration in the fluid. Very good. So here, focal zones, how do they work?
So like the way the beam comes out of the probe, there's a narrow zone, focal zone, and a far zone. And so you get the best lateral resolution in the focal zone. So then you adjust it to see your area of interest to put it in the focal zone.
And how does the probe do that we can change where the focal zone, where the beam is the narrowest?
So then you adjust, like, I guess, the length, the wavelength.
I mean, the wavelength affects it, but there's another way. So if you have like one wavelength, and in this case, we have multiple focal zones, right?
Yeah.
So it doesn't change the wavelength for that,
Frequency.
or the frequency.
Oh.
There's another way we can focus the beam.
Steering, maybe?
It has to do with steering, yeah. So we basically, steering means moving it left, right, but you can also, how you fire them, basically offset in the periphery versus central will focus your beam. And is there a drawback of using a bunch of focal zones?
I think you get less contrast, or like less detail with more.
So it should make it sharper at each focal zone, right?
Yes, it should. But I guess you get less waves in each focal zone, since you're dividing them.
So maybe a little bit the opposite. It takes longer because we need, for each focal zone, we need to send in a pulse. And so if we average them together, our frame rate drops. And so then your image will look very choppy if you move it around. Here you can see it. Nobody would do that in ultrasound. I'm not doing ultrasound. So it was just an extreme example with 5 focal zones. Then the frame rate dropped down to 2 frames per second. Also with this really large depth, that didn't help with that. So more focal zones will make it a little sharper in different areas, but then your temporal resolution drops. So the beam focusing, which is related to beam steering that you had mentioned. Okay, so.
Yeah, and we got Hawaida.
Okay, yeah. So we have ultrasound at the level of the gallbladder, and there is calcification with posterior acoustic shadowing. So yeah, the calcification is reflecting back the sound. That's why we see shadowing, because it's not penetrating through.
Okay, very good. And so now we've put Doppler on it.
So that's a twinkle artifact, which is the equivalent on Doppler ultrasound.
Yes, very good. And does the waveform help you?
Yeah, there is no pulsation, so it's not an artery.
Exactly right.
Or a vessel.
Very good. So twinkling, so bladder and shadowing, and then the twinkle artifact in there just with random Doppler signal. I think it's still not entirely clear what causes that, if it's jitter or just those reflection in between the rough surfaces, but we know what it looks like. So, and that was very good.
Okay, so here we have what is the apparent step off at the level of the liver. So we see this like step off of the echogenicity at that level, because there is probably a fat echogenicity lesion in the liver, and the ultrasound is the refraction of ultrasound at the change in speed between the liver tissue that's normal and the liver tissue that's fatty will cause this apparent step off.
Very good. Yeah. And so the speed difference is the key thing. So it will just take the beam a little bit longer to get through fat. And since the ultrasound machine takes the length it takes the echo to come back as a measure of depth, it will then put everything a little bit deeper when the fat is in the beam. Excellent.
All right, and then we have Elizabeth next.
Okay. Looks like that there's a hypoechoic mass or region on that ultrasound, and it's probably got increased through transmission, giving the brightness behind it.
Exactly right. And so why is it brighter than even the superficial tissue here? What makes it extra bright?
It has something to do with the propagation, I think, through the fluid.
Okay, so it's propagating through the fluid, doesn't get attenuated much, but then it's brighter than the normal tissue next to it, right? And the tissue here maintains relatively similar brightness. There's something we do to make that happen.
Harmonics, maybe?
And not harmonics here, just and it's my apologies, all of it, guess what I'm thinking. But we're doing a compensation to make the image look more even in the brightness of the echoes.
How about time gain compensation?
Time gain compensation, exactly right. And so we try to compensate just for the attenuation of the beam going through the tissue. And so when there is no attenuation, then it basically gets compensated more than it should, because it just doesn't lose any energy there. And that's the reason that it looks brighter than everything else. Okay. So the time gain compensation is the reason that it's so bright. Okay, here another.
All right, my next one. I think we're getting a mirror image artifact of the liver, like reflecting over that echogenic diaphragm into the lung space.
Exactly right. Perfect. So mirror artifact, and so it gets reflected in diaphragm, and so it projects whatever you see there into what's deep to it, and it even looks a little bit the echotexture like the liver that we're seeing there. Very good. All right.
Yeah, so we have Anurag next.
Okay. What can explain the echogenic fluid in the gallbladder seen on one view only? So that's probably the artifact from the adjacent bowel. I forget what the name of this is. But the bowel loop right next to it is, I mean, it gets refracted, and then it appears that the bowel loop is kind of projecting onto that gallbladder wall.
Yeah, so it is something that we're seeing that's not really right there. It's not so much a reflection. So there's something called a side lobe here.
Yeah. Sorry, side lobe. Yeah, exactly.
So just something outside the beam that then gets mapped into the beam, or the main beam, since there are those additional parts. Okay. What is harmonic imaging?
Okay, so instead of the primary wavelength, the harmonics are taken into consideration when reconstructing the image. They don't have the side lobe artifacts and other artifacts, and they have a better image quality, especially with cystic structures.
Yeah, good. So we're listening to the harmonics coming back rather than the primary echo. And there was a question and difference between side lobe and beam width artifact. And honestly, I'm not familiar with the term beam width artifact. I could imagine it's the same, but I would have to check on that. And what I'll do is I will, because I don't want to tell you something incorrect. I've since I'm not doing much ultrasound. I will post that in the physics channel on Discord afterwards. So ultrasound, I don't know if I can ask my colleague that does ultrasound. I'm not sure if he has handouts. If he does, I will ask if he's willing to share them on Discord. So I'll just take a note real quick. All right, so we're good. Harmonic imaging. Oh, for today's lecture. Well, I think what we'll have is I don't have a handout of this currently, but there will be a video recording available for the Discord members. So. All right, so hey, next.
Okay, yeah, we have Kunal coming up.
Hey, okay, so what causes the bright lines? Let's see. So the bright lines, so are these bright lines potentially caused by, let's see, just the differences in attenuation maybe between the tissue types?
And they kind of regularly spaced somewhat. Yeah. Think of how that can happen as an artifact. So there's no interface there where those lines are.
Okay. I'm not totally sure on this one.
Okay. So reverb artifacts or reverberation. So if you have two echogenic interfaces, it can be just the skin surface where the probe is and then something else. The beam can bounce back and forth between them before it actually returns to the probe. And that delays the echo, and then it gets mapped deeper than it should be. And so you can see that between two echogenic interfaces. Okay.
Okay, so what is the mechanical index and how can it be reduced? So I think the mechanical index is like the index or like the ability of the beam to generate like cavitation, which is like a mechanical effect that can occur. And I think you can reduce that by reducing the power of the beam, or maybe even the which could be related to like the frequency of the wave.
Mm-hmm.
So I think like higher frequencies would probably reduce the mechanical index.
Exactly right. So higher frequency. So it's defined as the peak negative pressure divided by the square root of the ultrasound frequency. And so as you increase the frequency, your mechanical index goes down. And as you said, it's related to the cavitation bioeffects. And so a higher frequency decreases it. Also greater focal zone depth, because that's then the beam is more attenuated before it gets focused to an area. And the output, as you mentioned. Very good.
Okay, and then we have Yuhao next.
What is the difference between color Doppler and power Doppler? I guess with color Doppler, you're able to tell both like the direction and the amplitude, whereas with the direction of velocity based on I guess, Doppler physics based on how fast, based on the frequency change of the initial wave that you sent out. Whereas power Doppler, I think you're only able to tell the amplitude, you're not able to tell the velocity, or sorry, the direction.
Yes.
With color Doppler, you can get aliasing. I don't think you can get that with the power Doppler.
Excellent. Yeah, so power Doppler looks at the amplitudes only, no velocity or directional information, but it's more sensitive. So you see low velocity flow better. And it's not as much affected by a Doppler angle, but more prone to flash artifact.
I think this is trying to show like a case of aliasing. In order to reduce it, I think the only way I know is basically to increase your scale so that higher velocity waves or higher velocity flow would be able to be mapped into that scale.
Okay. And do you know when you change the scale, what the machine changes? Or what does it need to change to do that?
Ooh, I wonder if it's, sorry, I don't know.
Yeah, but that was, you're absolutely correct. So it's related to the pulse repetition frequency. And so basically more pulses, and then there's less aliasing, and also lower depth can help because then the machine doesn't have to wait as long for the echo to come back. You can also affect it otherwise with the Doppler angle. So if you change the angle, then you can either increase or decrease your risk of aliasing. Smaller angle increases it, larger angle decreases it. So good. Let's see. Bleeding artifact. That's from too low a color scale. I'm not familiar with the term bleeding artifact, so I guess that's another one. I mean, the color scale would relate to, again, the velocity range that you have. So I'm wondering if the bleeding is another word for aliasing. So by increasing that, it affects the pulse repetition frequency and the ability to detect higher velocities. Since it effectively, it doesn't go by the frequency shift, but the phase shift, which puts limits on there, what it can do. So let me confirm that this term I have not encountered before, so I will also post that on the physics channel in RAD Discord. My apologies for the ultrasound is not an area that I work with, and so I have certain knowledge, but I'm not as familiar and not in depth in it like in some other areas.
And we have Mitch.
Okay.
Okay. What is the best range for Doppler angle? Oh, this is the one that has to be less than 90 degrees, but they prefer to be lower than 60.
Yeah. So, what's the drawback if your Doppler angle is too high or too low?
So if it's too high, meaning like between 60 to 90, I think you under represent the velocity.
Can we correct for that?
Yeah, and then if you have a a lower angle, like closer to 0, then that gets closer to the true velocity, but I can't remember if you can over-represent it or not.
Yeah, I mean, you can over-represent if you tell the machine the wrong angle, since we have to draw it on it, and it basically will compensate. So if we have this angle, and it basically knows that if the vessel is at an angle, we only see a component of the velocity, and so it will basically correct for that by multiplying for that. So if your angle is 0, then basically you're measuring, as you said, a true velocity. If your angle gets to 90, then you basically don't have any velocity in the direction of the beam, and so you wouldn't see anything, and the multiplication factor would get greater and greater. And then your error would get greater and greater because you're just amplifying everything. And I think this is somebody posted that this is maybe what is also called bleeding artifact. So I'll just show that one. So where the tissue around it appears to have Doppler signal just from the vibrations from the vessel that's adjacent to it. So I'm familiar with it under the tissue vibration artifact, but that would fit with the description. I'm just not, as I said, sure if that's also referred to as bleeding artifact. So I will verify that and post that. So it's vibration in tissues, and since Doppler doesn't care what's moving, it just shows also tissue that's moving. All right. Next question.
Yep, and then we're at Maria.
Facial compound imaging. I know it's where you take images from different angles, so you decrease your posterior acoustic enhancement or shadowing artifacts.
Yeah, so it's a combination.
Yeah, steering maybe, yeah.
Of the different angles, and there's also less speckle, and we define structures better. But because similar to the focal zones, it's more individual acquisitions that contribute to one image, the frame rate drops. Okay.
What is the reason for appearance of blood flow in the bladder? So is this the same from like a side lobe artifact where something from the periphery appears in the bladder?
Well, some theory maybe, but here, since we're in the urinary bladder, so what else could be picked up there?
Oh, the ureters, the jets.
Yeah, the jets.
Oh, okay.
Yeah, so it's just, we need to remember that color shows us everything that's moving, not only blood. And so if we're worried that there's a tumor in there, and that could potentially be a side lobe artifact that makes it look like there's something sitting in the bladder and could look like a mass, and then you turn on Doppler and you see this, you might think, oh, there's vascular tissue in there. So those two could go together.
Okay, and then if Hawaida can take this on.
What is the name and cause of this artifact? So we are at the level of the aorta, proximal aorta, and we see Doppler outside of the aorta. So would that be the same thing from vibration of tissue adjacent to the aorta? I'm not sure.
Yeah, it's, I guess they sometimes call it a little bit differently, but it can be just gross tissue movement. So I mean, from pulsation, maybe with the other one, it could be just a vibration from a buoy, and here it can be just gross movement from bowel moving or pulsation of a large vessel or so that moves the entire tissue. But I mean, the principle is kind of the same. I think you're absolutely correct there. So it's also called a flash artifact. And okay, getting to the end here. What is the thermal index?
Okay, so the thermal index is basically the bio effects that's caused by the ultrasound.
Mhm.
It's basically like it will be displayed on the ultrasound screen, and it's how much heating is caused by the absorption of the ultrasound waves.
Okay. And do you know how they calculate it? Or
I just usually read it in the right upper corner.
okay. Yeah. So basically the idea is that they're looking in the acoustic power at the depth of interest, and they divide it by the power needed to raise tissue temperature by 1 degree. So this 1 degree temperature increase is basically the reference. And so they're relating that relative to that. And so for first trimester scanning should be below 1, for example. Okay.
Okay, and then next up will be Anurag.
Okay, what is acoustic impedance and how is it relevant for ultrasound? So I guess acoustic impedance is how much is the how's the beam impeded by the tissue. Essentially, it measures resistance, like acoustic resistance in the tissue. How is it relevant for ultrasound? It's essentially important for image formation. If it's higher, rays can get reflected, or if there's an acute change in acoustic impedance. I know it's also used for one of the shear, like RFE. You can calculate the shear velocity and use that information to assess the stiffness of the tissue.
Do you know what tissue properties in terms of ultrasound go into impedance?
What tissue elasticity?
Not direct elasticity.
I don't know, someone put in the chat density. I honestly don't know.
Yeah, so density and velocity. So that's how they define it. It's the density of the tissue divided by the speed of sound in the tissue. And the relevance is, and you had mentioned that basically when there are interfaces at tissues of different acoustic impedance, then we get reflection of sound. And so that's when we see interfaces.
Okay.
Okay.
Am I still going or?
Yeah, I think
Okay.
one more and then.
Okay, diffuse versus specular reflector. So specular is, which is like, it can reflect in multiple directions. So it's kind of rough no, the opposite. I guess specular is something that reflects in one direction. It's kind of smooth enough as compared to the wavelength of the sound.
Mhm.
And diffuse is something which is rough as compared to the wavelength. So it can like diffusely reflect and doesn't form a good interface for the, yeah.
Very good. I have to say, I find those terms very counterintuitive and not very helpful.
I'm glad you think similar.
Yeah, it's just specular sounds like something really small. I'm not sure why they chose that, but you were exactly right. So a smooth interface from which the waves are reflected, and diffuse are really small, smaller than the wavelengths that scatter it into all directions. So that is all I have. And thank you for you guys that are willing to take cases. It's not an easy thing to do. And so I appreciate it.
Thank you, Dr. Rassner. This was awesome. Thank you for the residents who joined, and we hope that everybody found this useful. And if you could please fill out the feedback survey in the chat. That is just posted. We'll appreciate your feedback.
Okay.
Good luck. Take care.
Thank you. Thanks for managing everything and hosting here and moderating. I appreciate that.
Thank you, Dr. Rassner. Do you have any specific feedback for the session, how we could improve for next time?
No, I think it worked well, but I'm happy also if there are other suggestions to adjust things. I mean, the goal is it should be useful to you guys, and so whatever I can do to make it more effective, I'm happy to do. Just let me know.
That's good. Thank you.
Yeah.
I think there is a question in the chat.
Yeah, impedance. I mean, there are different types of impedance in physics, but acoustic impedance is this density versus speed of sound. So I think sometimes people just say impedance because when you're talking ultrasound, that's what it's going to be.